Well, good evening, ladies and gentlemen. First of all, thank you, Elizabeth. Thank you, Rod. It's a pleasure again to be giving a small presentation. I thought I'd just make a small comment about Sharon's work on the cure for HIV. When I was working on a PhD about 17 years ago, sitting in Sri Lanka, sipping a cup of tea, working on the economics of HIV, on the economic impacts of HIV, I certainly heard of an article in Nature which said that a cure had been found. And that was probably the most disruptive moment of my life. I said, oh God, there goes my PhD. but then I said, you know what? The Sri Lankan tea is nice, let's relax, tomorrow's another day. And luckily enough, a week later, the paper was retracted. It was from Nature. It was in the mid-90s. So there it was. How did I get into health? Well, that's another story, long story, but I think what's interesting from health is actually, this PhD continued, and I was sitting at a meeting giving a talk when some minister got up and said, so tell me, have you ever seen a primary health center? And I realized I actually had not. And that I actually knew very little about health systems and how health services get delivered. So much of what I have done over the last 16, 17 years is try to fill up that particular knowledge gap. And while I don't promise to sort of cover that 17 years in the next 10 minutes, I certainly hope that some of that will seep through in the next 10 minutes. So the question for this particular panel is there a financial fix for global health? And with some trepidation, I actually walked across to my neighbor, B.B. Loff, who's a very outspoken person who I respect a lot, and whose views I wanted to sort of get at this topic. And she said, what, is this a multiple choice question? The answer is no. And she walked off. And that led me to think again, what do we do with this? Is there really no financial fix? But after all, I'm an economist. I mean, we always find uses for money. So what exactly did I do? I actually went and looked up some data. This rather ugly but sort of long rising bars essentially indicates money is given by global aid giving agencies, the World Bank, multilateral, bilateral, the Gates Foundation, and so forth. And as you will see, and if you can read the numbers, starting from 5.7 billion in 1990 to 27 billion. It's a lot of money annually given over the years. And you might say, well, at least a lot of people have found worth 27 billion worth of money useful for health. But actually, this is pretty small potatoes. The real action is happening in terms of spending by governments and households. And that is really big time money. So we are looking at trillions now, forget billions. Starting from $2.6 trillion in 1995, the world today spends roughly $7 trillion on health. The health sector is by a long margin the world's biggest economic sector. If you're an economist, you should be concerned about health. And so certainly a heck of a lot of people believe that money is important, and money is really important for health. In what way? Most of us know the answers, but I thought I might also give you a little historical sort of perspective. And what I did was to actually go back and look at some data on improved health over the last 50, 60 years in the world. And what I found was the following. So I picked 6 countries: China, India, Japan, Uganda, United States, and United Kingdom. And the richer countries, Japan, US, and UK, essentially are listed on top. And those have seen an increase in life expectancy from 70 years at birth to about a little bit above 80 over the last 50 years, 10 years extra. But if you start looking at India and China, the red and the blue, and forgetting some data issues, these countries actually gained over 30 years in the last 30 years of expectancy of life in the last 50 years. You might say, well, that's big, but not that big. But it's actually very big if you appreciate that, in fact, these 30 years exceed the advancement of the entire human history, 200,000 years plus. Assuming that people could not have lived at less than 20 years of age for the human race to have survived over time, that means they could have at most gained 20 years over the previous 200,000 years of life. So in the last 50 years, we've gained more in terms of health, in terms of life expectancy, compared to the previous 200,000 years. So where did this come from? Where did this massive improvement in health outcomes come from? One theory is nutrition, and certainly people like Robert Fogel from the University of Chicago believes that, in fact, it's improved nutrition, and that could be the argument made for gains in expectancy in life in the late 18th century and early 19th century Britain or France. But actually, the story is even more compelling after that period. And that story is this. And these curves essentially, on the x-axis what you have are incomes listed, per capita incomes. On the y-axis you have life expectancy at birth of countries. So any particular plot essentially is telling you what the distribution of life expectancy is across different countries with different levels of income. And what you see is richer countries tend to have greater life expectancy, i.e., and if you believe in Bob Fogel's argument, that in fact people who, the nutrition could be explained at least part of the story. And perhaps, and this by the way, these curves are known as Preston curves, and the person who actually developed these curves argued that in fact another reason could be that richer countries tend to be able to afford better health services. Simply larger numbers of primary health centers, hospitals, and so forth. But what might amaze you is in fact that this curve, which might suggest to you that incomes cause a rise in health, or at least are an important driver rises in health, actually does not even explain half the rise in improved health over the periods. What has really explained increases in life expectancy over time in countries is not this movement along the curve, but shifts in it through technological changes. So a same country which is living at, which had per capita incomes of $500 per person in 1950 could be increasing a much lengthier life per person in 1980, simply because of improved technological setups that improved health. So what might those be? Well, certainly improved nutrition was an initial change, but beginning in the early 20th century, you had public health improvements, access to clean water. You had access to antibiotics beginning in the 1940s and 50s. And then in fact, in the mid 70s and in the late 60s, early 70s, you had improvements in cardiovascular disease mortality. And then of course, more recently, declines in neonatal mortality. So effectively, these technological changes in fact explain a much greater jump in life expectancy than rises in incomes alone. So where did these gains come from? From thin air? Probably not. They come from important investments, financial investments in health. So my point therefore is that in fact, money does matter and can matter a heck of a lot in terms of pure technological changes. And so I would tell Bibi, if I had to meet her again, that in fact, you missed the point. But actually she has a fairly fundamental grain of truth, and that's where she's coming from is where in fact I was hit 15 years ago, which is in fact what she was referring to are other issues that have to be addressed. Certainly technology matters and it should be funded, and because technological changes have explained some significant improvements in life expectancy. However, I'm going to use 3 examples to argue that in fact this is not enough. In fact, we should think about money as explaining only part of the story in terms of improved outcomes. So what are those 3 examples? The first example is what I like to refer to as a last mile problem in health. Essentially the idea that yes, you have improved average health outcomes, yes, you have achieved declines in infant mortality at birth, but what you haven't done is reached people at the lower end of the income scale. People who live sort of far beyond, well, in remote areas, native population, tribal populations, and of course people who tend to be poor, whether it's urban areas or rural areas. And this you can see in country after country. Take for example India, a country I know quite well. Certainly it's seen massive declines in infant mortality over the years, but I looked at the data today for 2012, and in fact the lowest infant mortality rate in the state of Kerala is 1/4 that. In fact, 1/5 that of the state with the highest infant mortality, which is a state called Chhattisgarh. It's no longer Bihar, by the way. Bihar is the bad person for every visiting professor, but Bihar is doing fine. It's Chhattisgarh which is the problem. But it's a huge difference. And the question is, why is the difference there? I'm not going to give an answer right now, this very second, but certainly it's a question that one might want to pose if one wants to think about money being the answer. So the last mile problem, in my opinion, is actually quite a significant one. I thought another example of the last mile problem is trying to catch those last 10, 20 cases of polio. Of course, in India, they managed to catch them, although I don't quite know how good the data is. But certainly, what you have are these 4 countries. There's, of course, you would recognize Oluge's country, Nigeria, out there. And the next to it is Chad, and then, of course, you have the Pakistan, Afghanistan. And what's common to these countries? Essentially, in this particular area certainly is some sort of ethnic strife, perhaps, some religious angle as well, and I'll let Ologe discuss this more fully in case the panel ever reaches that particular stage. But the point is that there are communities, groups, often at the extreme end of the religious scale or living in conflicted societies, where in fact health systems or monies simply can't. I mean, nobody can seriously argue that Afghanistan is lacking in money. I mean, or even parts of northern Pakistan. And money is being thrown in that area like nobody's business. The fact of the matter is, there are important challenges. I mean, polio, in fact, still remains, and I looked at the latest data today. So, the other issue is the graying of the world population, and here the problem is slightly different. The first one is about reaching the marginal populations, the poor, and so forth. The second one has to do with the fact that it's possible that all the money that you can throw at this problem may not be enough. Look at the situation in India, and this is the proportion of population aged 65 and over listed for these different countries. In the year 2010, the share is about 7 to 8% in India and China. But by the time we reach 2050, we're talking of a population that could very well exceed 15 to 20% of the total population. Now, it's one thing to argue that the elderly will live on current level of healthcare services for the foreseeable future. If that's the argument, well, in fact, certainly you can afford to have the elderly till whenever. But in fact, chances are, as incomes rise, the elderly will demand better health services. In fact, they will not have enough children to support them. The traditional family is going down, is declining. The people don't have any children. The joint family system is going down. So at some level, these individuals will have to fend for themselves. Or if not fend for themselves, certainly they'll have to find supports from somewhere else. And that's going to essentially come down to where do you find the money. And in fact, if you allow for the fact that there's going to be technological change, some of which will of course occur over time, but in these cases, in fact, in these countries, you can simply ship the technology straight from the OECD countries, developed countries, straight to the developing countries. Much of the developments in the non-communicable disease treatment, cardiovascular disease or stroke and so forth, is simply making its way to the developing world. And nowadays, if a new scanning technology gets developed in Australia or the US or UK, well, next week it's in India. It's a world of difference today. But that, of course, means money. And somebody's got to find that money. And the point is that, in fact, that money may be very hard to find because the amounts involved could be gigantic. We're not talking of small increases. So yes, if you had unlimited amounts of money, if you could get hold of that planet made of diamonds, you'd be fine. But in general, it'll be difficult. The third issue, nasty surprises. It's all very well if you can predict the future, but the future tends to be unpredictable. This, of course, those of you who know, well, hospitals would recognize this as the NIH hospital in Maryland, which had this super bug which they've been trying to control for the last 1 year. They've been busy destroying the hospital and remaking it. And they had the 7th test, I think, last month. But of course, what I haven't discussed is the super bug in India, which they found, which the Indian government denies. Chances are that handling these sorts of cases is not simply a problem about money. It raises other issues, disease surveillance. It raises issues about, again, health systems. People often argue that misuse of antibiotics, whether in animal farming or whether in the case of self-medication for no reason at all, may very well be a driver of resistance over time. But of course, these nasty surprises can come in other forms. In the year, I think, 1993, the state of Maharashtra in India had a big earthquake. And although they had heard that the area that had the earthquake was plague-prone, they never bothered about this. Well, plague did occur. It led to a massive movement. It actually, for some reason, it got transferred to a city called Surat, which is a city of a couple of million people. It led to massive numbers of people migrating pell-mell all across the country and led to a major public health crisis. Again, no amount of money can actually address, or at least system that actually, if you simply throw money at a problem, which basic disease surveillance systems, basic public health norms, unless those are covered, you basically will not be able to. And again, the point here is that you need to spend the money in the right area. And of course, then we have this. Suppose you did have money, and suppose you did want to address problems with money. So here we have last year the government of India had an expert panel which suggested that India should treble its allocations to health. The planning ministry agreed, the government agreed, and that was fantastic. 3 times its current allocation to health services. This year they announced in July that in October, starting October in fact it's probably happened, they will be distributing free drugs to everyone who visits a public facility. Generic drugs, of course. But right there, at the same time, India becomes a hub for fake medicines. And in fact, it's a serious hub. I mean, even with about 1,000 drug inspectors in a country that size, they've been able to find that at least 5% of drugs are fake. My guess is if they did a more careful study with more inspectors, the number would be much, much higher. And of course, in the state of Uttar Pradesh, where I am from, of the total allocation of $1.9 billion under a big scheme called the National Rural Health Mission, 1.5 was stolen. So then you wonder how much money can get you. I thought I'll sort of conclude with a quick look at some of my work, which is sort of dealing with the so-called last mile problem. This is actually a village in eastern Maharashtra. This is a community health worker. These, in fact, are the poor people, low, underpaid, struggling at the margins, trying to take care of the people. I mean, almost all of the national programs are on their broad shoulders, if you will. These people are probably getting about $50 a month, and basically every single national program lands upon their shoulders. And so the question is, well, even if you throw money at the problem, where does the money go? And at some level, to me, that's the major challenge. So in conclusion, since I know I have only 10 minutes, it's not that finances are not a potential fix. In fact, I believe in quite the opposite. In fact, you need money, but they will not be enough without implementation mechanisms. And in fact, I believe at the end that I think what we have is a lot of high quality technical research, and we need to continue supporting that. But I think we also start need to think about how we can support the knowledge implementation gap. I think that's where the big action is, at least from my point of view. So I'll stop here. Thank you very much.